Hi, everyone. Welcome back to another one of our amazing guest mentor series for the month. Today, we have with us Will Martin from SOAR Autism Center. And we are very excited to have you with us today, Will.
Thanks, Jamie. Super excited to be here.
Yeah, can you kick it off by telling us a little bit about your background and maybe a little bit about SOAR for people who aren't familiar with you?
Yeah, for sure. So I'm a behavior analyst by training, and I've been in the field of ABA since 2011. With the first 2 years or so, I was the equivalent of an RBT at the time and have been a BCBA for about 10 years. I'm also an ESDM certified therapist and recently was accepted into the apprentice trainer program. So I'm working through that, which is very exciting. My job at SOAR Autism Center is head of ESDM implementation, and SOAR is a naturalistic developmentally focused ABA provider. We use the Early Start Denver model, or ESDM, as our primary care model, and we deliver those services in community-funded clinics or community-centered clinics through insurance-funded models in Colorado and Arizona. And so my goal and my job is really to bring ESDM and ESDM-based practices into community-based clinics where we have the constraints of insurance funding and of RBT turnover and clinician training and all of those things, but trying to bring the amazing science and model of ESDM into a community-based clinic where we work kind of through all of those constraints. And so I supervise a lot of our clinician and RBT trainers. I've designed a lot of our training model. And then I also really monitor our outcomes with some support from the rest of our team to look at the effectiveness of our model. How are we seeing kids succeed? Where are we seeing some gaps there? And try and just really bring our ESDM-based model to life in our day-to-day work. So right now we have 7 centers in Colorado, and we have 1 in Arizona. And we are growing and hiring clinicians and RBTs, and it's been great to see a model that was not available widely in these places, kind of have how interested and excited families are to have NDBI-based practice in their community, and really how stoked therapists and RBTs are to learn more about it and to just implement a model that they feel good about with kids learning through play. And there's a lot of fun interactions in our center, and it just has been really rewarding. So yeah, it's a little about me.
Great. That's great. I didn't realize you guys had 7 centers in
We
Colorado.
do.
That's
Yeah. And so we're all in the Denver area,
kind of the
and we're in
metro.
kind of some in Denver proper, but most in the suburbs like Aurora and Arvada, Westminster. And so Denver is sort of has the urban sprawl thing going on. And so our centers are dispersed throughout the area, and then they have filled up quickly, which is a good thing. But once they're full, as you know, in center-based care, the thing you need to do is add another center because they stay full for a couple of years. And so it's been really exciting.
That's great. And it sounds like you guys have a really good method for how you're scaling everything out to keep these centers going and keep that high quality service that you guys offer. And I want to pick your brain a bit more on kind of supporting staff
Sure.
and quality program development, because I think you ticked off so many things in the applied arena and that kind of gap from research to practice where we live and work for a lot of community-based providers who are struggling with, hey, I really want to implement this, but pitfall, what do I do? So it'd be great to hear your thoughts on some of the things that you guys have worked through and might still be working through as you grow it
Yeah.
more.
For sure. I kind of look at it on 2 different levels. One is like if you're, the leader of an organization and you want to bring NDBIs into your practice, or if you are a BCBA working at a large organization or a small organization and you want to bring NDBIs to your caseload. I think that those are 2 different levels to consider. I'll start with the big picture one and talk about some of the stuff that we're doing at SOAR. Really what we've tried to do is add a level of standardization to what we're doing, and then make sure that we have the right resources available to staff and to RBTs to bring this to life. And so on the RBT level, we've created our own 40-hour training that's approved by the BACB. We cover all of the ABA content. but we do it through an ESDM lens. So when we're talking about prompting and reinforcement, we're talking about prompting and reinforcement within a joint activity routine during a play routine, and then have RBTs go out and practice that, as they're completing their training, so that we're not sending them to a course that's standardized and recorded about, very structured ABA, and then asking them to do something totally different. So we've built our own RBT training program. We've extended it from 1 week to 2 weeks before RBTs get onto the floor, and have some, we call them centralized RBT trainers, who really help, kind of do like a lecture on the different topic. We have some recorded video content, and then there's a lot of coaching and feedback. So it's a very, I think, personalized approach to RBT training. And we found that that really helps RBTs come in with a better understanding of what NDBIs are and kind of what an ESDM focused practice looks like. And we find that often we hear from RBTs who are experienced and have been in the field, they're like, well, this is different, but I also see the connections between reinforcement and prompting and a well-constructed teaching trial. But we have to kind of bring those things together on the front end. And then essentially what we do for our RBTs is we try and monitor treatment fidelity on a regular basis, and then incentivize improved fidelity to our model with promotions and increased compensation and all of those good things. And so we have developed an internal tool to measure fidelity. We're incorporating the ESDM fidelity system, which is in the blue book, if you all are familiar with that, into our practice. But we've also have a simplified model for RBTs that is really looking at the core components or foundational skills of a joint activity routine. And we basically assess them on that throughout supervision. And then we have an assessment team. We call them our DDC evaluators, or direct delivery checklist evaluators. And they evaluate RBTs on a quarterly basis, and that they have an opportunity to get promoted, to earn more, and to get some feedback on their practice from a team of folks who are just focused on treatment fidelity. And so we found that that really drives motivation for our staff to improve in our model. And so I think the measurement of fidelity is really, really important. Sorry, I know I'm going on about this.
No, it's brilliant. And I think that ties right back into those outcomes that I know you're going to talk about. Fidelity, how we do with that, how our clinicians and our technicians do with that as it relates to client outcomes. So really interesting data set that I'm sure you guys have there to kind of look at the progress and the progression of staff fidelity, and also looking at those beautiful child outcomes that you're tracking as well.
Yeah, they're very closely related. And I think, to be transparent and honest, our fidelity still has room to grow. And we're working with our clinical advisors like Lori Bismara, who I know that you know and has maybe talked to this group before too, which is cool, to really bring some of the true ESDM fidelity system to our practice at the RBT and clinician level more. But what we have seen is that as we've monitored fidelity and as we've looked at fidelity, that our kind of client outcomes have continued to increase. And we measure that using the ESDM curriculum checklist. We look at the median skills gained across all the kids at SOAR, plus Vineland checklist growth, which we use the Vineland, which is a standardized measure that looks at child development and those sorts of things. And so what we found in both of those is that our Vineland scores are increasing, not by a full standard deviation for every kid, but on average, it's about a half standard deviation per 6 months, which is pretty cool, because the Vineland gets harder as kids get older, because it's a standardized developmental measure. And we find that on average across all kids at SOAR that we average about 60 skills gained on the ESDM checklist per 6 month period of time. And some kids greatly exceed that and are gaining hundreds of skills. Other kids we're finding are not responding at the same rate. And we're using the ESDM decision tree to add some more structure to kind of formalize what that looks like. But we have seen really good outcomes from this model. And we know that our fidelity is not where we want it to be and where we want it to be in kind of like a final state. But it is really encouraging to me to see that, a model of ESDM, which is not at what I would call like research grade, like we're not quite there, but has the core values of ESDM and has some of the principles imbued in it, is getting outcomes that are similar to what we see in some of the peer-reviewed research.
Yes, and you just said something, and I'm looking over here, I'm trying to think of who it was. When I was doing my dissertation, it was all on play-based NDBIs in England, and I came across
cool.
Yeah, it was, I think Laura Schreibman was one of the main authors. I'm going to find it and send it to you. But it was all about predictors of what types of profiles for children do best with the play-based approach versus
Yeah.
Shared one. And maybe that is something that would help you guys as you tease through those children that are not progressing as quickly. Do they fit that profile that she talked about in that research study? Because the ones in my dissertation, there were 2 out of the 9 of these multiple baseline parent dyads that did
Uh-huh.
not progress like the other children on their ESDM checklist, but they fit the profile: low imitation skills, not interested in toys. And there was one other one, and they fit right into that. So it's really interesting
Oh,
is
super cool.
yeah, I'm gonna find it for you. I know I have it saved. I was quickly trying to see if I could get it over here on the
Yeah, if you could email that to me, that would be awesome. I'd love to
yes.
read that.
Yeah.
Before I worked at SOAR, I worked at Vanderbilt Medical Center in Nashville, and I was working in Paul Yoder's lab. And Paul Yoder is awesome. He's a great
Mhm.
researcher and just a wonderful person too. But he did a lot of research on trying to predict what skills led to the development of things like verbal speech or kind of more independence with daily living. And I worked on a project there called the Tadpole Project, where we compared an NDBI ESDM based approach to a DTT based approach. And part of that study was we tried to predict who would respond better to one versus the other based on their profile at intake.
Uh-huh.
And in that particular study, we were actually unsuccessful. We
Mhm.
couldn't really predict who would respond to the more structured approach versus the less structured approach of ESDM. And sometimes it was actually the reverse of what we thought, where a child who started with, relatively fewer skills compared to other kids progressed rapidly once they learned some of those prerequisites to play and joint attention skills. But it wasn't always that way. There were some profiles of kids or some individuals that still weren't making progress at the same rate. And I think we're trying to understand that more at SOAR. And I think just as a field, we need to better understand why are there these kids that take
Yeah.
off and make, progress in other children or other profiles of children who make progress, but at a much slower rate.
Especially if you're really aligning that fidelity, like, hey, everyone's at 80% whatever fidelity across
Yeah.
the board. You're rocking it out. It's looking good, but you still have those stragglers and those kind of extraneous kind of blips on the data. Those children that do have a different trajectory in terms of their learning rate to kind of figure out what is the best way to support them to get that generalized, maximal, kind of efficient learning for them to go through it. And I think it's really interesting to kind of highlight learner profiles. How are children learning? And like you said, that decision tree, it changes
Mhm.
from moment to moment, from day to day, from treatment goal to treatment goal. So having that clinical ability to shift and pivot as needed to really kind of align what teaching approach is going to be best for what child under what context. And I call
Yeah.
them clinical decision-making skills, CDMs in the moment. How do
Yeah.
we adjust and teach staff to do that? And fidelity is a big part of that because that goes back into the teaching. That sounds like a
Yeah.
really fascinating study.
Yeah, it's really interesting. And I think one of the ways that it comes to life in our work at SOAR is we're talking to families. A lot of times we're the first kind of intensive service provider that they've encountered. And families want to know, like, what is a good outcome for my child, or what should I expect the outcome to be for my child? And I still feel like, as a field of behavior analysis or early intervention, we still can't answer that question because it's variable. Some kids, the outcome is they go to a typical classroom and they're mainstreamed in education and they need very little support moving forward. And other times, a good outcome is a child who has a successful communication system, might need lifelong, support at some level and intensive special education services, but is, not engaging in high rates of behavior that could be dangerous to themselves or others, can communicate independently, can go through daily living routines independently. And so, when you're talking to a parent and they have an 18-month-old child that they're trusting you to serve and to help, it can be hard to, say, yeah, this is what you can expect in 6 months or a year. And I think as a field, we're still grappling with how we define
Mhm.
what is a successful intervention, and how do we know if we really maximized our time.
Yeah, and I think, gosh, wouldn't it be great to have that crystal ball to shake into
Right.
the future? And I just don't have one. I'd love to get one. But also to think about maybe operationally defining success, like what is
Mhm.
socially significant and meaningful for one family is going to be different for another. So one family who can get their child to dress themselves and be more independent with those types of skills might reduce their stress, let them have time to do other things. That might be a huge success and win for them. And then on the other hand, there might be another family where that's not so much a priority, but they really want vocal speech, verbal speech. They really want to have conversations with their child. So I think part of that, I know for me, has always been, well, what's important to the family? Because that's, I think, how they define outcome, progress, and success, and in a way that's meaningful to them. But we still love to look at our data and the standardized kind of checklist and whatnot, because it's kind of a roadmap of where we're going to kind of close that gap, if we will. I think that's
Yeah.
tricky to do too. It's like, well, it depends. It's variable, like you said.
Yeah. It's variable. And then as a field, I feel like we're also reckoning with like, what is our purpose? What are we trying to do for each individual person?
Mhm.
20, 30 years ago, there was this concept of indistinguishable from their peers. And I think if you'd ask a lot of providers, and especially like autistic people, they would say like, that's actually not the goal that I'm aiming for. I want to be, my true authentic self, but be able to be independent and make decisions about how I spend my time and where I spend my time. And so I think there's a lot of work just as a
Mhm.
field and for SOAR as an organization to think about what is a socially meaningful
Yeah,
result for every child we work with, how do we match that up with their family's values, and then how does
yeah.
that respect and build that person up as their own unique individual too.
Yeah, and then segueing into, because you're in the private funding arena, how do we
We
make
are.
that translate into a language that the funders find valuable? They want to see the data, they want to see the outcome, they want to see those metrics.
Exactly.
Yeah. And then trying to balance that. Well, yeah, we see what you want, but we're saying this is also meaningful for a family. Yeah, I don't miss being in the private arena dealing with insurance funding at all. Not one day have I missed it at all.
It's always a journey, and I think we've learned what each different payers seem to value different things and
Yeah.
seem to value different focuses, and they definitely have things that they definitely see as off limits. And in
Mm,
Colorado, one of those things is anything for many of our payers in Colorado, they don't want us working on things that could be considered like cognitive behavior therapy, like coping skills. And so we
wow.
need to think about, as we're writing our goals and framing what we're doing, how do we tie this back to our core,
Mm,
purpose as an NDBI focused organization, but then also communicate, we're not trying to teach this child skills that a psychologist would teach them, but we are trying to help them be more independent. And one of those things might be self-advocacy or asking for a
agree.
break or those sorts of things. And that there can be a difference between functional communication and like I think it's like some of our payers see it as coping skills or things that would be
Mhm.
more within a psychologist's purview, and so we've really kind of had to pull those pieces apart and be really thoughtful. And one example of how we help this family make sure that their child can advocate for what they need and not feel like they have to go to these more extreme places with challenging behavior, but also stay within our defined lane, which is often, unfortunately or fortunately, depend on how you look at it, defined by
Yeah.
the insurance companies or payers that we work with.
I know. That's interesting to me, to coping skills, because I think a lot about co-regulation, self-regulation. That's teaching children how to kind of cope and regulate themselves. Would they push back on that? Or is it the words that you use to present it to them that varies?
I think it depends on how you talk about it. We
Okay.
know that it's the average behavior analyst doesn't have a lot of background on in child development and how children develop and the skills that are key for that. And so I would extend that it may be fairly or unfairly to the average insurance reviewer too, that they might not have that background on the difference between providing services to an 18-month-old versus to a 17-year-old. And
Mhm.
so I think it's often really tying it back to the developmental milestones and tying it back to some of the language and the skills that are in things like the Vineland and the ESDM checklist, and being very intentional with how we're talking about what we're doing, and being very specific with what we're talking about, so that our our pairs don't misconstrue or misunderstand what we're trying to achieve. So
Yeah.
I think we actually, and especially when I do some of these calls with pairs and I actually talk to the reviewer, oftentimes they're like, hey, you just need to reword what you're saying to make it clear that you're staying within your lane. And so
Yep.
what you just said, Jamie, I think you just need to be thoughtful about how you're describing it and how it helps this child with kind of the core challenges that are common in autism.
Yes, and I always try to tell people, anchor it back to that DSM-5. Put your goal
Yep.
under it, and then it's beautiful. They know exactly what you're doing to remediate deficits related to whatever it is, and then it's all tied together. Because I think you're right. Some of the people who are reviewing the plans, the treatment plans, the learning objectives might not truly understand what we're trying to do in any arena, or they might really be kind of honed into more of the DTT type teaching, ABA traditional type of programs, because that's what they've been funding consistently for so many years. And
Exactly.
now here comes more NDBI type approaches where the goals might look a little bit differently or the focus might shift a little bit, but we're still working towards supporting medical necessity as it relates to what they are paying to fund.
Exactly. Yeah. And I also put some of the onus on the behavior analysts that I work with to be clear and to be, conceptually systematic with what we're doing and operationally define everything that we're doing so that, a layperson can understand what we're telling them. I often find that it's a mismatch between what we think we're doing and what the provider or the payer thinks we're doing, and that's where really
But
the
that good.
disconnect is. And
Yes.
so I think there's a responsibility on both to be clear and to be really true to our science about how we define things clearly and really make sure that we highlight the social validity too.
I agree. And I think it's right that communication and it's just a dissemination and education. Like, hey, we're talking
Yep.
about this, you're talking about this, let's meet in the middle. And again, get out of those pitfalls and things that we keep struggling with in the applied arena or community-based settings, like you said, where you guys hang out at SOAR and kind of work through those pain points, if you will, with the funders, with pediatricians or with whoever it is that's giving you referrals to come to you for these families to get access to services, to just kind of keep educating them. And I was
Yeah.
here thinking, and I'm like, I don't think I've ever asked you how you got into NDB. We've chatted a few times before, but I don't know how you got into NDBIs. Can you share?
Yeah, yeah, sure. Great question. And so I got started in this field in 2011, and I was an undergraduate at St. Joseph's University, which is a small school in Philly. And I was a psych major, and I didn't really know what to do with that. I just thought it was interesting. And so there happened to be an autism center on campus there. And so I got a work study job as basically the equivalent of an RBT. And we were doing, naturalistic based approaches, but it was more of like a
Mm.
summer camp type situation where we were, helping kids engage in summer camp type activities. We had like the Philly Fanatic
Oh,
come to the camp, and had interactions, and we would have some socially focused programs and things like that. But it was really, in hindsight, I thought that's what ABA was kind of like, facilitating these community interactions. But I learned that there's also kind of these other camps of behavior analysis. And so I decided I wanted to be a BCBA, and like, this is what I want to do. And so I was going to grad school, and I was like, I'm going to be a DTT guy, and I'm gonna, be into structured teaching. I think this is how, people with autism learn, and this is really the flag I'm gonna put in the ground on what I want to do. But in doing that, I went to grad school at the University of Pittsburgh, and I actually went to an early intervention program. And so all of the people in my graduate program were studying to be developmental therapists and work in the early intervention system. And then I was there. And all the parents that I worked with, or not parents, all the professors I worked with, many of them were parents of children with different diagnoses or special needs, and they got into this field or to advocate and help with what they need. And so I was like, I'm going to be the structured teaching person because that's what I think is right. And I was surrounded by this group of people who was all about naturalistic intervention and bringing this to families'
you're
homes.
lucky.
And I remember we did this exercise where we put like DRI floor time on one side of the chalkboard and like low VOS DTT on the other side of the chalkboard, and had people like tally where they fall. My first year of grad school, I was like all the way over here. I'm like, we're going to be very regimented and structured. And then
All
I
by
actually had
yourself.
some Yeah, I actually had some practicum experiences where I told my supervisor, I want to do like DTT and structured teaching. And they said, okay, do it. So I was like, oh, great, let's do this. And it was not what I thought it was going to be. And so it's like, kids were unhappy. I was unhappy. The cards weren't laminated. The
Oh,
materials were destroyed. We had the tackle
binder.
box looking
Yeah.
thing with the edibles in it that, and
Knackle box. Yep.
yeah, and so the perception I had from reading the Cooper book on like what DTT was and then what it actually was in practice was quite different. So I was fortunate enough that in grad school I got trained to do a project impact focused project using Brooke Ingersoll's work, working with parents who had younger children. They were parents of children with autism, and this project was focused on their younger siblings. Exactly, that
Happen to
book.
have that right
Um,
here next to me. If you guys aren't looking
yeah,
at that, I can
and
put a link.
so I really got to see through that work the transformative practice of NDBIs. I don't think at the time I knew that they were NDBIs, but I just saw like, this is a 12-month-old and a parent, and I can tell them these play strategies and they can really do them, and they can do them at their house, and they can do them with the teddy bear and the plate and cup that they have in their kitchen, and they don't need my tackle box that has old Cheetos and cards and things like that. Like that's totally unnecessary. And
Yeah.
in fact, it might even be worse. It might even be harmful. And so I was kind of trying to grapple with this, and had really decided from that point that what I thought I wanted to do and what I actually need to do are quite different. And so really brought project impact into my practice. Finished grad school, passed the BCBA exam, began working in kind of community practice and trying to forge my own path on, figuring out, as when you get into community practice, there's no guidelines. They just give you a caseload and they say,
So
you want to do the ESDM checklist? You want to do the VP map? Like no one tells you. And so I was kind of figuring it out. And I was fortunate enough a couple years after I got started as a BCBA to get the job that I described at Vanderbilt Medical Center. And from there, I worked with Lisa Wallace, who's an ESDM trainer, and in Paul Yoder's lab to lead this ESDM team who was implementing ESDM in families' homes in Clarksville, Tennessee, which is a military community about an hour from Nashville. And so I, went from sort of kind of doing NDBIs, like trying my best, to having like some really world-class training in ESDM in particular. And I got to visit the Mind Institute and meet Sally and do all of those things. And I worked there for 5 years, and that really cemented NDBIs as the core part of my practice. And so, fortunately, that's was a great experience. And Lisa is on our advisory board here at SOAR and is helping us do our work here, which is really cool for me to have a mentor who's still involved at that level. But when I got connected with SOAR and they were talking about, what should our model be, I was no longer waffling on where we need to be on the Likert scale, So it became a core part of my practice and something that I'm really passionate about. And as I've learned more about things like advocacy in the autistic community and what developmentally appropriate intervention looks like, and honestly, what typical community-based ABA looks like, I think I've become stronger in my position that NDBIs and ESDM is the right way to go about this, especially for young kids. So I know that it was a long answer, but it was kind of a journey to get to where I am, and I'm really fortunate to have a lot of lucky consequences, I think, along the way.
I'm with you. I would plant my flag in that hill right next to yours. That's the hill we'll die on. It just is helpful and better for these children. And if you think about it from a strength-based approach, what's neurodiversity and affirming? What is going to maximize the fun for the things that you can do with them together to get that connection, to get that communication and learning going? NDBIs just naturally afford so many opportunities to do that. And then you think about all of the stuff, I think, with like heavily prompt dependent children. And I'm like, oh, it's just because the teaching is off, and the teaching is off because the goals are developmentally off. And those are off because you're not using a curriculum checklist or a standardized assessment that's looking at those foundational skills for social communication. So I love what you guys are doing for the conceptually systematic approach to training, not just your technicians, but also your clinicians, because
Yeah.
it trickles back up to what's coming down. The people on the ground are only doing what they're told to do, and the people up here are only doing what they know to do. So if you have the opportunity to shape those repertoires, if you will, and that's what you're doing, you would expect to see those really great outcomes that you guys are able to track, which is exciting.
Yeah, and to your point about clinicians doing what they know how to do, that has been one of the challenges and kind of things that we've needed to support clinicians with at SOAR is that, I mean, 99% of the SLPs, OTs, and behavior analysts that we hire have never done naturalistic intervention before, or they've done naturalistic intervention before, but they've never done ESDM before.
Mm-hmm.
And so, we're starting oftentimes with trying to build up those repertoires from scratch. And what we found is we really have to standardize a lot of our approach. So we have a goal bank that has basically every item from the ESDM checklist broken down into a starting place for goals with some pre-written learning steps that we expect people to customize, but we've had to have a really strong point of view on what we are doing and not doing.
Yep.
Similarly, we've said we're not restraint training any of our people here. We're not training RBTs in physical management. We're not allowing that as part of our behavior plans. So we're working with 2-year-olds, and we just don't think that that's safe or necessary or creates the environment that we want here. And so oftentimes, clinicians are excited to learn and they're stoked to learn. They want to become ESDM certified. And we have, 6 people who have become ESDM certified at SOAR, which is really cool. But we've had to have some of these strong positions, and that can, I think, ruffle some feathers in a field where people are very sure that they're right, myself included. I fall into that category. I feel very sure about what we're doing here, but oftentimes we need to make sure we have that philosophical match with the clinicians that we're working with, and then that we upskill them and provide them with the resources that they need to be successful. And so that's an active kind of process, but I think we're getting better at it to make sure that clinicians who are now in charge of supervising our direct care staff have the resources and support to do that well.
Yeah, absolutely. And I think that's a big thing because, like we were talking about before, NDBIs have been around for quite a while, but the umbrella term, 2015, and kind of came out with Schreibman's article. So it's new to some people on the term, the umbrella, and also thinking about most programs. I'm not going to say all, but I would say most programs don't have a course on NDBI at a university setting. So
Or even child development.
yes, so where they might be getting any knowledge or education before they come to you or another ABA center, you don't know what you're going to get. So I think some people come in and they don't know and they want to learn. And then other providers, nope, I got my degree 1 year ago. I'm a fresh BCBA. I know everything, right? You've seen them, I'm sure.
Yeah.
So it's about that, finding that really good fit of aligning everything of well, you might know everything in your year 1 exposure, but that's great, good for you. But what we're trying to do here is to kind of open people's eyes about a different way. And it would be different than I think for most traditional ABA programs, for most people coming out. And I don't know the scene in Colorado I don't think there's a whole lot of ESDM in Arizona. So
There's not.
none in Iowa
Yeah.
where I'm at. So everyone is looking at me like, what are you talking about? So I think that's interesting how you find people and how you guys are really creating and cultivating a culture of this is what we're all about and this is what we do. And if you can get on board with this, then you're going to do well
Then
here.
we'll train you. Yeah.
Yes.
Yeah. We
You don't have
found
to
it's
have it.
about
Yeah.
Yeah, we found it's about being clear with folks about what they're signing up for, trying to be as clear as possible. As when I was in community practice before I worked at Vandy, it was like I was like the naturalistic teaching guy, and then my colleague would be like the DTT person, and then there'd be like a life skills person, but there was no standardization. You showed up at this center in Raleigh, North Carolina, and if you got assigned to me, you got this style of intervention. If you get assigned to my colleague, you got that style of intervention. And we're trying to that's not what we're doing at SOAR. We try and be really upfront with clinicians that we have boundaries on where our care model is. We have boundaries with the age of kids we serve, with the population that we serve, and we have boundaries for clinicians on what types of interventions are inbounds and out of bounds.
Yeah.
Yeah, and what's inbounds is this ESDM focused model. We teach through joint activity routines, and we modify using the decision tree if kids aren't responding. And so it's not that we only do one thing, and if it works, great, and if it doesn't work, too bad, but we have a sequence to modify it. But that we are saying, if you want to do a strict DTT LOVA style program, this isn't the place for you. And I think I hope that as a field, we start to
Mhm.
do that more, because, you know, a lot of, I think our big box providers,
Mm,
it just depends on who you get assigned. And, you
right.
know, could your intervention or your child's experience could be extremely variable just depending on the person. And everyone says they're doing naturalistic intervention, but I actually don't think that they are. And so I think we need to get stricter basically on on defining what we do, and really putting it out there, put out the outcomes that we get, and how we get there. And and we tried to do that. We had a webinar where we did some of that, and we shared the data really
That was great.
transparently. And I hope that we see more of that in our field, especially in community practice, not just the research community.
Yeah, for sure. And I know you guys give those every once in a while. And if there is a link that the members can, I can put on our recording here. I always put little show notes. If there's a link that I could put on there for them to email or get on that list to learn when those come out, I would highly recommend them doing so. Because I
Yeah.
had that last talk and it was brilliant. It was great to see the data and to look at that and to think about that is, in my mind, a dream place to put the children that I work with and specialize in, the little learners, right? And that's what they need. Do you have any advice for practitioners who are starting out with NDBIs, who might be in the trenches of trying to make that shift happen to really get it into their organization? Any advice or lessons learned that you'd want to share?
Yeah. Yeah, I can try and share some. I think for individual providers, to me, it's about finding a community of like-minded professionals, which is part of, I think, what you're doing here, Jamie, is that, you know, oftentimes I was the guy using the ESDM checklist, but everyone was like, okay, like we're gonna keep doing this over here. And so I think, you know, oftentimes BCBAs are isolated to their role and their caseload. And so whether that's, you know, Facebook groups, which are surprisingly productive sometimes in our field, or, you know, actual people in your community wherever you practice to connect with around these things. I think that's really important. When I left Vandy, I worked at another provider before I worked here, and no one knew anything about NDBIs, and so I did some trainings about what it was and that sort of stuff. But everyone was kind of like, cool, we're going to do our thing, you know, which is their prerogative. But I think getting connected with other like-minded providers is really, really important. And I think
Agree.
if you're at a place where you want to try and, you know, pitch this as a more standardized model for your clinic or for your group or for, you know, your team, I found that looking at the research and the data and bringing the data is really important. There's this perception in our field that NDBIs are kinder, but they're less effective than DTT. And I think it's because they're play-based and they're fun. And I think a lot of people do these strict regimented interventions because they think they have to. But when you look at the data and the direct comparisons between the two, actually it's shown that they're equally effective. There's no advantage in terms of rate of acquisition to DTT versus NDBIs. And so I think we have to start to break that stigma and really say, you know, this is not a more fun but less effective version of ABA. Like, this is just as good. It's actually better because it's more developmentally informed. And so I think that having those conversations with colleagues, if you're going to ABAI, I'll be there. I'll be talking about outcomes. And so I'm excited to do that. But, you know, talking to colleagues and talking to others about, like, it's not that it's not as good, it's just as good, or it might, again, even be better, is really, really important. So if you're going to approach your clinical director, if you're a clinical director approaching your, you know, center leadership team, I think having the data to show, one, that this is just as effective, if not better, and two, that there's existing resources that we can use to bring this to life. We don't have to write the book. There's a book, you can buy it on Amazon. There's a curriculum checklist, we can buy it on Amazon. There's a parent manual, you can buy it and bring it to your clinic. You know, that there's actually a lot of resources already that
Manualize.
exist to bring it to life. You know, I think sometimes people go like, well, how do we do it? It's like, well, instead of doing the VB map, you do the ESDM checklist, and you can make a grid in Excel that looks just the same and presents the results in a similar way. And so you can start to really get a one-to-one, you know, connection between what you're doing now and maybe what you want to do. I would also really recommend that you continue to find opportunities to learn more. I still feel like I'm learning from people like you, Jamie, and Lori Bismara, and others in the ESDM community. And so whether that's through the official certification track, through the UC Davis Mind Institute, free continuing education opportunities, a combination of both, there's a lot of good resources out there that can help people get prepared and really competent in this work. And they're often freely available or low cost if you're not prepared to make a big investment in the official certification process. So I think that's generally what my advice would be.
Yeah, that's great. I love it. That's going to be so helpful. And then I'll email you and see if there's any links that you can think about.
Yeah.
The SOAR website on there, just for people to learn more. Maybe people are interested in moving to Colorado and you see some of these
Yeah.
job
Well,
applicants come your way. So that could be really exciting as well.
yeah, the mountains are beautiful in Colorado. We get I think it's 300 days of sunshine a year. So and there's no humidity. So it's very dry and there's snow in the winter. So there's a lot of advantages.
I'll put a
But
link for the
yeah.
application for the job. I'll just put it right here in the notes.
But I'm happy to share some links with you.
That would be
We have
great.
those CEUs, they're posted on our website, and they're free for folks. You might get an email from someone asking you about openings in Colorado afterwards, but I think it's a fair trade. And so I'll be sure to connect you with those resources.
Oh, it was wonderful having you here. Thank you for your time and for chatting with everyone.
Yeah, thanks for having me, Jamie. Really appreciate it.
You're very welcome.